Hello, good afternoon. Today my talk is going to be on dermatology in infants and young children. It'll be divided into three topics: infantile hemangioma and its treatment, secondly, atopic dermatitis, and thirdly, Staphylococcal scolded skin syndrome. This is an infection that occurs in neonates and young children. Infantile hemangiomas are benign proliferation of endothelial tissue. They occur in 10% of infants, mainly in premature female and Caucasian infants. Treatment depends on the position on the body and the numbers of hemangioma. 55% of them develop at birth and present as thread-like lesions called telangiectasia. The hemangioma then grows in size until the child is about 6 to 8 months. They plateau at the age of 1 year before spontaneous, but can be very slow resolution. This is a slide of infantile superficial hemangioma or strawberry birthmark. So when to be concerned about hemangioma? The periocular or around the eye area. This could lead to damage of the sight of the child. If the hemangioma is large, it can cause ulceration and scarring. If it's down in the lumbosacral area, it can cause damage to the spinal cord. The beard distribution is if you have a large hemangioma around the face and neck area. This also may signify another condition called phases syndrome, which has heart and brain involvement. Then if there is multiple hemangioma, that usually about 5 or more, that actually may signify internal involvement, so an internal hemangioma, usually in the liver. So most hemangiomas do not require treatment. The exceptions being if they are around the nose, the lips, and the ears, if they are ulcerating, if it is interfering with the important functions, such as one down in the perineal area, or if it's going to cause any cosmetic defects, if it's on the face. If infants are suitable for treatment with propranolol, they are fast-tracked by their GP to the main children's hospitals around the country. Propranolol is a beta blocker, and it was discovered by accident in France in 2008. The mode of action is still unknown. It is given according to the weight of the child in 2 or 3 divided doses a day. Due to its effect on the heart, infants are always assessed by a pediatrician prior to starting. Some infants, usually low birth weight or premature, will need hospitalizations and have investigations such as an ECG or an echo prior to starting. The most severe side effects would be your hypoglycemia and hypotension. In this slide, it shows you 3 photos. Firstly, when it was prior to starting propranolol, and then in the second photo, even after 24 hours, it actually shows some changes in the hemangioma. And then in 18 weeks, it shows a great improvement. So the side effects, I already talked about hypotension and hypoglycemia. Wheeze and bradycardia are symptoms that rarely occur. Often there is sleep disturbance, cool, mottled hands or fingers and toes, and usually in the first week there may be some diarrhea. Education of the parent or carer regarding propranolol is very important. The dosage is fully explained, and there's actually three or four strengths of propranolol, so the correct strength will be advised. The feeding regime is important. Infants are usually fed 4 to 8 hourly, depending on their age and weight, throughout the day and night. The side effects are explained thoroughly to the parents so that they know if the child is off form to suspend treatment. They need to attend monthly appointments so we can see how they're getting on and increase the dose according to their weight. Here's a slide of an ulcerated hemangioma. Ulceration occurs in 5% of the hemangiomas. The mean period of healing is 93 days. Pain is severe and there is always scarring. All ulcerated lesions require dressings. The aim is to heal, prevent infection, and reduce pain. Wound care using non-adherent dressings is applied, such as Mepitel and Mepilex. If it looks infected, a swab is taken. Topical or systemic antibiotics will be prescribed with or without dressings with silver. All ulcerated hemangiomas are painful, especially when exposed to the air, so pain relief prior to dressing is important. Non-medicinal forms of pain relief include feeding and limiting exposure to the air also. Resolution or involution. This resolution could take many years, sometimes from 3 up to 5 years. Laser treatment may be required at 5 years, and a referral could be made to the dermatology clinic to see if laser can be done. Plastic surgery is also an option for excess tissue removal. So my next topic is atopic dermatitis. Atopic eczema or dermatitis is a chronic inflammatory pruritic skin disease, often occurring in families with one or more atopic conditions such as asthma or hay fever. It affects 20% of children in the UK, and at the moment we don't have statistics of it in Ireland, but we presume it's similar. 3 factors involved in eczema. There's skin barrier abnormalities, there's defects in the immune response, and there's altered skin microbial flora. Here's a photo of an infant with the typical facial eczema. Again, on the body, it is widespread in infants. So the presentation, atopic dermatitis can start from 2 months of age, and the presentation for children older than 2 years or for children at 2 years is the face and body. Over 2 years, it moves to the flexures, that's your wrists, your elbows, and the backs of the knees and the ankles. So daily skin care is very important in the management of eczema. Unfortunately, all the parents have to do the majority of this work themselves. The word moisturizing emollients mean the same and are interchangeable. Emollients are divided into creams, ointments, gels, and then there's also lotions. Emollient can be used in 3 ways: as a moisturizer, if it's diluted with hot water, as a bath oil, and then thirdly, as a soap substitute. It's very important for carers to wash their hands before applying topical therapy, avoid bacterial and also food contamination. You can decant the emollient from a tub using a clean spatula. Apply emollients in a thin downward fashion. Apply emollients half an hour after application of topical steroid. And emollients can be applied 2 to 3 times daily, 3 times, especially in the winter time. An emollient bath is necessary on a daily basis. This is done for 5 to 7 minutes in tepid warm water. You can explain to parents this softens, cleans the skin, and prevents infection by removing scale, crust, and blood. After the bath, pat the skin rather than rubbing the skin. Now, topical steroids. Topical steroids are classified according to the strength. So in the first category, we've got mild steroid, which is hydrocortisone ointment, Dactocort, which is used for yeast flare-ups, and Fusidin H, which is used for bacterial flare-ups. These can be used on the infant's face. Then we've got moderate. These are used on the body, Umivate and Betnavate ORD. And also potent steroid can be used, Loicoid, Elicon, Travacort, which has got an antifungal or anti-yeast component, and Fusibet, antibacterial. And very potent, we don't use in infants or children. So the fingertip unit is a guide for parents and carers, and it shows how much steroid the parent should apply according to the age of the child. In this next slide, it shows an infection on the face. The main growth of bacteria is Staphylococcus aureus. If the infection is localized, it is treated with topical antibiotic and steroid. If the infection is widespread, it is treated with an oral antibiotic. Flare-ups can be caused by house dust mite, animal dander, fragrances, pollen, teething, or kind of a physical stress such as cold and flu, and especially in the winter time when you see a change of temperature, central heating, or when the child gets too hot. So in summary, daily management and skincare routine is very important. Topical steroid therapy is ongoing, prescribed daily for flare-ups, and reduced to a maintenance dose when the flare-ups subside. Now for my third topic is Staphylococcal Scolded Skin Syndrome. And as I said, it's an infection caused by toxins being released from bacteria, Staphylococcal. It causes damage to the outer layer of skin, causing it to become red. It appears scalded, so hence the name of staph scalded skin. The child will present symptoms such as lethargy and fever. A rash can develop after when it becomes infected within 24 to 48 hours. The tissue paper-like wrinkling appears on the skin. This is followed by blisters, some of which are small or very large. The top layer of skin begins peeling off, leaving red, moist areas that are quite painful. So treatment in hospital of staph scalded skin is IV antibiotics, including penicillin and flucloxacillin for 48 hours. Paraffin gel is applied to the skin 3-hourly. Emollient and antiseptic bath for 5 minutes on a day, every day. For moist, weeping areas, apply the dressing for fragile skin, such as Mepitil or Mepilex. And pain relief is very important. Infants will be discharged home when the wounds have healed and when they are able to tolerate oral antibiotic. Wounds improve very quickly, but parents have to be educated about the application of paraffin gel and the emollient and antiseptic bathing. Wounds heal within 3 weeks, so there is no need for hospital follow-up.
Thank you, Karen.
Thank you.
Thank you, Karen, for that wonderful talk. We certainly have learned a lot from your talk today. And I suppose I'd just like to say that the Irish Skin Foundation Ask a Nurse helpline is a very valuable free service that we as nurses in the community, we should be actively promoting. I have certainly found it very beneficial in my practice. So I'd like to again thank you very much, Karen, for that wonderful presentation. Thank you.
Okay.